Very good evening to everyone, and I would like to extend a warm welcome to our 18th POWWOW session. I am Dr. Astha Bansal, a second year PG here at SN Chennai, and I would like to welcome Dr. Akshay Badkare sir to take over as moderator of today's session. Over to you, sir.
Thanks, Asta. So, good evening, everyone. And it's a nice sessions that we've been having for the past few months now. And the idea is to actually connect with the alumni and discuss some cases in a very informal and informal manner where we all get to learn. So today we have Dr. Akshaya. She did her fellowship with us in Shankar Netralaya and finished in 2022. So she'll be presenting two cases. First one is a case of extraocular eye movement disorder, which finally turned out to be myasthenia, but it mimicked a lot of conditions when she evaluated it initially. And the second case is of ocular albinism with an abnormal head posture, which she managed. So over to you, Akshaya. You can start now.
Good evening, everyone. I'm very glad to be a part of this program. So I'm presenting two cases. So the first case I just titled it as Twist the Tail. So this was a 27-year-old male who presented with history of outward deviation of right eye for the past 5 years. He consulted elsewhere in GP dentistry for the same problem, where he was given some exercises and glasses. So he has history of wheezing since birth, no other systemic problems. History of presenting illness, he was apparently normal 5 years back and then developed outward deviation of right eye, noticed more for distance. He feels it was sudden in onset, but he was not very sure of the graduality of the problem. But the deviation was not progressive since 5 years, and he felt there was no diurnal variation of deviation. There was no pain. It was not associated with double vision or abnormal head posture. But he did have some asthenopia and vision blurring during computer work, and he was doing some exercises. There was no history of ocular or head trauma or surgery, and no history of patching in childhood, no family history of squint. And he had a history of COVID-19 vaccination roughly around 5 years back at the time where his symptoms started. And he did not have systemic history, symptoms like jaw claudication, fever, weight loss, limb weakness, dysphagia, dysarthria, shortness of breath, or headache. And he did not have any known thyroid disorders. So at presentation, when I looked at him, this is how he looked. He had no abnormal head posture. He was fixing with his left eye. For distance, he had a manifest right ectodeviation with a right hypertropia, but both eyes were central steady maintained. His right palpable fissure was little smaller than the left, and left showed a little lid retraction with no lid lag. And Worth dot for distance was right suppression, and near stereo was 200 arc seconds. So he had an IXT to RXT R over L of 75 to 80 basin and 30 R over L and manifest for distance. And his near deviation was 25 basin with 30 R over L, but he was dilated, he was controlling well. So vision in the right eye was 6, 9, and 6. Best corrected was 6, 6, and 6, and left eye was 6, 6, and 6. So this was his ocular motility. So we could see that in the primary deviation for near, he had a good control. There was a small palpable fissure size difference. And in the right eye, he had an inferior oblique overaction, probably here. And there was a small change in the palpable fissure aperture on the right gaze. So looking at all this, my initial impression was maybe it was just an intermittent exotropia with a manifest deviation and a good control for near and with an inferior oblique overaction and a pattern deviation. So I called him for a patch test and gaze measurements undilated. So these were his after patch, post patch measurements. So there was a V pattern, 70 basin in the up gaze, 50 basin in the down gaze, and it was 30 R over in primary up and down gaze. But there was a remarkable incompetence in the R over L in the lateral gazes. It was 56 in the right gaze and 30 in the left gaze. And the right tilt was 40, left tilt was 30. So then I thought probably I was dealing with some oblique palsy. So I went back and actually, as per the Park's three-step test, it pointed towards the left inferior oblique palsy. So I wanted to go and see if he had any facial asymmetry or an AHP that I might have missed. So looking at this picture, probably he has a right side of the face smaller than the left side because of a right head tilt, but that did not point towards a left inferior oblique palsy. And his fundus showed an intorsion. So when his fundus showed an intorsion and he had a slight ptosis of the right eye and he had an hyperdeviation and an intorsion of the fundus and a medial and also adduction was limited, which is actually seen in this video here at the right eye. I also did adduction test to see the adductions of the right eye. So then I found that the adduction was limited, and then probably depression in abduction was limited, and there was a palpable fissure change, which I had shown in the previous picture. So in the left eye, he also showed something like a narrowing of palpable fissure in the left in abduction and and a widening in abduction. So these were his lid fissure changes with ocular motility. So then I also had a doubt whether it was some third nerve palsy with an aberrant regeneration, but he did not have a history of trauma or no other history suggesting a previous third nerve palsy. And MRI brain and orbit was normal because I was not sure whether it was an oblique palsy or a third nerve palsy. And then I took a look at the video again. So I wanted to show this in the video. So soon after the right eyelid was elevated, the left eyelid was drooping further than the right eye, was drooping more than the right eye. And in the abduction of the left eye, there was a small hop of the lid. Probably that was a Kogan's lid twitch. And this was the curtain sign that was present for him, which I had missed. And I told him to get photos of taken during various times of the day, but I still couldn't see any variability of his ptosis or his deviation from his photos. So I planned to do a thyroid test and a test for myasthenia, and it came positive for acetylcholine receptor. And then he was started receptor antibodies. So he was started on Graviter and Predmet. And 2 months later, he presented to me with an improvement in the ptosis, but his deviation the horizontal deviation remained the same. There was a dramatic change in the R over L, which was concomitant horizontally. And this was him after 2 months of the treatment with Graviter and steroids. And this was his photo taken yesterday evening. So why did I have so much of diagnostic dilemma in this case? Because he did not have history of diplopia at all. And then he was able to control the angles for near. And then fatigability test, actually I had tried the fatigability test, but I understood that it is not sufficient to diagnose an ocular myasthenia clinically. Is this a case of an IXT and an ocular myasthenia that we're dealing with? Because the treatment has actually reversed, or it has bettered his vertical deviation and ptosis, but the horizontal deviation is still remaining the same. So I went through a lot of literature and I understood some things about myasthenia. So myasthenia can present with no diplopia and no diurnal variation. And even for a simple palpable fissure height difference in both eyes, which looks like ptosis, it is better to do an ice pack test and a curtain sign. And there's something called a Darpel sign for myasthenia test, which is the same fatigability test that we do, wherein we ask the patient to look up 30 seconds, but that has to be repeated 5 times to prove that there is fatigability. And for every large vertical deviation, we have to evaluate for thyroid eye disease and ocular myasthenia. And usually ocular myasthenia presents after 70 years of age in men and less than 40 years in women, but it can also present in young men, and it can present with unilateral ptosis and external ophthalmoplegia. I also found from literature that there can be accommodative changes like accommodation lag, accommodation infacility, accommodation excess that can occur in myasthenia, ocular myasthenia, which can be an early sign of ocular myasthenia also, probably because of which he had that control of deviation for near. And I also came across a paper which said that even after standard, therapy for ocular myasthenia, there can be still persistence of ptosis and exotropia. And there were also papers on COVID-19 vaccination inducing an ocular myasthenia. The patient had had the symptoms around that time, the time of he had the COVID vaccination. And generally, differentials for a large vertical or primarily vertical deviation, first thing should be an exopalsy unless proved otherwise. Sometimes an iopalsy, MED Brown's, orbital floor fracture if there is history of trauma. And if there is a large vertical with large horizontal, then it can, with comitance, it can be an IXT with a pattern deviation. If it's incomitant, a third nerve palsy, which will have ptosis and adduction limitation. If it has adduction limitation, we'll have to look for an abduction nystagmus to see if it's internuclear ophthalmoplegia. We have to rule out a thyroid eye disease if there is lid retraction, lid lag, proptosis, and a myasthenia gravis, which can mimic any of these conditions. So management, we have to continue the neurologist management, probably wait for 6 months to even 1 year for stability of angles. So I want the expert opinion on the approach of such approach and management of such cases. So that is my first case.
Thanks, Akshaya. Thanks a lot. I think we'll take some questions. I would like to ask the panel. Dr. Soumya, what's your take on this? I mean, this is a case wherein she has beautifully recorded the videos. She's gone back to the video and found some signs. So could it be that this patient had a V pattern exotropia and along with some concomitant signs of myasthenia? And to Dr. Rishi also, I would like to ask the next question. You have done some work, and I believe you're going to present in AIOC also on your take on ocular myasthenia and its varied presentations. So we'll go to Dr. Soumya first.
Nice case, Akshaya. Well presented. There are certain things which are not very clear. Like if we looked at the 9-gaze photograph, there is an adduction limitation in both the eye, predominantly in the right eye than in the left eye. Something that she also mentioned as inverse DRS, where the palpable fissure changes in the right eye are very, very obvious compared to the other eye, especially in the right case, that the narrowing on abduction and widening on the adduction, which is predominantly seen in the right eye. That is something that is a clue towards probably we're not dealing with a regular case of an IXT because there is a definite palpable fissure changes happening there. The adduction limitation is probably giving us or pointing towards a V pattern rather than the regular V pattern here. Because of the adduction limitation, probably we're getting larger XT in up gaze compared to the down gaze is what at the outset that we could see from the picture. What is more probably added to the confusion is he has had a large XT. It has lasted for 5 years and your sensory testing is showing a suppression. So, and you said that it's controlled well for near and he's able to control. The fact that he has a suppression and he has a very good control, probably there is a discrepancy in what we're dealing with here. The clinical signs are not correlating one with the other.
Just for that moment, ma'am, he uses the accommodative convergence and he just controls from here. And this thing, when we take a photo, it is controlled for near, but when we do tests like stereopsis and all that, he is not able to.
Okay.
It just deviates quickly. I mean, I should have not told good control for near. That's not good control for near. That's just accommodative convergence.
Okay. No, the reason why I was mentioning was your 9-gaze photograph is showing like completely ortho in the primary gaze in one of the pictures that you showed, not the one that you put it up primarily, but the 9-gaze picture was seeming ortho. So that amount of control is a little hard to achieve unless the patient had a blurred vision. With a 70 XT, with, if you're presuming is an accommodative convergence, would definitely cause a blurred vision for him. And that would have been as one of his complaints. apart from the deviation of the eye, it's never been complained about blurring or double vision.
He had blurring of vision, for which he was given glasses and exercises previously. That
Okay.
was the complaint.
So probably those were the clues which were pointing towards not an IXT in the first place. In terms of it being a myasthenia or a combination is something very difficult to say at this point of time. In terms of just the presence of a receptor antibody without an actual doses. And in all your measurements, you've always got an XT, which has never changed at all. And the adduction movement limitation has not changed at all. It's just that the incompetence, which was like 20 prism diopters from right to left case, 30 and 56, which has come back to 30 and 30. That means one of the case has changed, the other case has not changed. So that is again not a pointer towards that your gravitar is working or your prednisolone is working, is what my thought process would be in terms of saying that, okay, it is a myasthenia which is working. Having said that, yes, we know that strabismus may or may not respond as good as a ptosis would respond to. But again, in this patient, the ptosis is not very predominant in the first place that we began with. It's just that there is an enhancement of the left droop when you lifted up the right eye, which may happen in other cases of ptosis also. Though it is one of the indicators for myasthenia, it need not happen in every. It can happen in other cases of ptosis also, is what I would be thinking in terms of. Kind of difficult to say that it's pointing towards either of it at the beginning, or to say it is carded as XT as a cause of, purely a myasthenia case, because there is absolutely no variability in the squint that we are looking at in all the measurements that you have taken pre, post dilation, after patch test, after 2 months. It's exactly, yeah. So that is what my take would be in terms of it probably needs, would be a good idea to take a measurements in the morning and in the evening, call towards the evening of the day and take a measurements again, just to see if we are missing out on small variability that we are looking at.
Okay.
And it will also be a good idea to do more tests for myasthenia before we concluded that yes, we are dealing with a case of ocular myasthenia.
RNS was done and it was negative. Repetitive nerve stimulation test was negative, anti-musk was negative, and thyroid function test and antibodies were negative. Only thing that came out positive was the ACH receptor. There is another receptor that is actually also involved in myasthenia, the lipoprotein 1, LP4.
LPR4.
LPR4. I think that has not been done.
But that mostly comes positive when you have a acetylcholine receptor or an anti-musk as negative. Since your acetylcholine receptor comes strongly positive. But the only thing which is going against us, if that is positive, then it should show a response to either your steroid, which will respond more to steroid in an ocular myasthenia, versus gravitar, which is not showing a response. So there is kind of overlap in either your clinical findings and the response to treatment both as well.
Okay.
So probably look at doing a clinical measurements again, and then repeat the acetylcholine receptor antibodies now, and then take a call before how you proceeded it further.
Thank you, ma'am. Dr. Rishi, you have done quite a bit of work on myasthenia. You have a paper, I believe, in AIOC also. So what have you seen? What have you come across? Have you seen cases like this where they present with an exotropia, signs of myasthenia?
I agree with Dr. Soumya. I hope I am audible.
Yes, you're audible. Yes.
The thing is, I'm still not completely convinced that this might be myasthenia. I still feel it can be a case of an exotropia. The study which we had conducted was for a different age group. It was for children till 16 years of age. Few things which we can extrapolate some of the data to the case which was presented. I feel, in all the cases we had ptosis as the prominent clinical sign. This case doesn't have a ptosis at all. And in myasthenia, the most common of the kind of squint is exotropia, which your case has shown. And there was some amount of lid twitch, if the video which you played.
Yes.
there appears to be a bit of lid twitch. Did you try, measuring in the morning and the evening blood test?
I didn't measure, sir, but I told him to send pictures that were taken in different times of the day. So
Okay.
he was able to give me that, but everything looked similar to me, the
Okay.
doses.
Okay. There are not much of diurnal variation as such.
Yes, yes.
Uh,
But I haven't done the measurements myself in different times of the day. He was able to come only towards the evening all the time.
Okay. The 8 cases which we presented or we studied, 4 cases had ophthalmoplegia, and all of them had exotropia. I mean, all the 4 cases which had exotropia. We conducted a tensilon test for them. We conducted neostigmine test. Tensilon is not available. So, under anesthetist guidance, and even the ophthalmoplegia showed improvement with the neostigmine test. So, I mean, I haven't done neostigmine test at this age did you try doing an neostigmine test to see
No,
or to?
no, so I had sent to the neurologist. He didn't do that. After RNS was negative and ACH receptor was positive, with that he started the medication.
Okay, so the only thing positive or going in favor of a myasthenia is the acetylcholine receptor test.
0.9, sir. Strongly positive.
Okay, and the treatment, how much duration of treatment has been given?
2 months. 2 months.
2 months. Okay.
With oral prednisolone and Gravitar.
Okay, yeah. I mean, there have been studies which indicate that only pyridostigmine without steroids can be given, especially for children. But all the cases which we studied were with steroids also, and definitely there was an improvement. Out of 8 cases, only couple of cases there was a recurrence after stopping the treatment, but rest of them they remitted completely.
So generally, how long should we wait for how long will the treatment go, sir, for myasthenia?
For children, it was 6 months. I mean, we for first 3 months there was no tapering. After 3 months, we gradually or slowly tapered both the pyridostigmine as well as the steroid, depending upon the response. Some amount of improvement was definitely there in all the cases at 3 months. So depending upon the response, we had to taper or alter the dose. But 6 months, all the patients received the medical treatment.
Okay, sir. Ma'am and sir, my two doubts are still there. Like, I don't know why he never had diplopia at all. I had been repeatedly asking that question. And second,
can I answer this?
yes.
The 8 cases which we studied, none of them complained of diplopia. Even the 4 who had ophthalmoplegia, they never complained of diplopia.
Okay.
So,
and about that narrowing of pressure and widening on adduction, like in inverse Duane's, is it only, related to the lid changes in myasthenia, or should I look into something else for that? So,
it's kind of very difficult to say, Akshay. Like, even your absence of diplopia, the fact that the patient has very good control, and whenever he squints, the angle is so large for him to decipher or tell you that he'll have a diplopia. If he had a smaller angle, probably he would have complained at least once in a while that he had diplopia. The fact that he has a 70 XT with a 30 R over L, the image is going to be far in the periphery for him to even notice it or get troubled by it or complain it. And the other times when he's able to control, like what you said, even momentarily, then he would not realize it. I would place more for the fact that that is why he is not complaining it. And with respect to palpebral fissure changes, I'm not convinced that it's just related to the lid changes. The adduction limitation has not changed even a bit, even with 2 months of therapy. That's unusual because I had a similar, not exactly a similar case. I had a young girl who had presented with. It so very looked like third nerve palsy with a fourth nerve involvement. It looked classical, like 2 nerves being involved. The only thing that was not going was I was not able to localize the lesion. I said, okay, I'll measure you back in the morning, and the measurements were completely different from what I've taken. I was like, had I measured this patient or the file has been missed? To that extent, it was completely different. That's the variability that you see. So, unlike in your case, I would probably look at repeating the acetylcholine receptor antibodies at a different lab and looking towards a diagnosis rather than looking at a lab test and fitting the patient into the diagnosis.
Okay.
Just a thought. Sorry, Dr. Soumya. Please go.
I was just mentioning that it would be a good idea to repeat the test before we concluded him as myasthenia, because with 2 months there is absolutely no change. And a good idea to do an ice pack test also and correlate it with even the palpebral fissure changes, what you're seeing. If it's more an adduction, take a measurement there, do an ice pack test and see if this variability in the adduction and abduction is that getting a little better. If we are
Okay.
presuming it is only because of myasthenia, at least that should get better with your ice practice. Combine both of it would give us a better sensitivity and specificity is what I would consider it as.
The neurologist had mentioned ice pack test positive in his report actually. I haven't done it, and should I try a diplopia charting and see, ma'am, or no use?
No, you could try it out and see.
Yeah, okay, ma'am.
Just a thought, is the steroid dose very less for his body weight? Because 8 milligrams, I think, twice a day. In 2016, I think there was an international consensus on ocular myasthenia, where guidelines came out which said that you could, if there was only ptosis, you could give a trial of pyridostigmine and see. But if there is ptosis with extraocular motility limitation, then you give about 35 to 40% of body weight. Because if you give too much of steroid, 1 milligram per kg body weight, that itself can cause some amount of myopathy. So it can confuse the picture further. So they said that if you give about 35 to 40% of body weight, that should be like an ideal dosage. So I'm just wondering, while we are debating that it may not be myasthenia and repeat the test again, is the steroid dose a bit less?
Because IVMP also has been studied also for myasthenia. I mean, when I came across the articles, they've even given intravenous steroids. But this seems to be very less.
Yeah.
And because the steroids have to be continued for a longer duration of time. So as Dr. Akshay suggested, you start with around 35-40% of the body weight. But yes, definitely the steroid which is being administered is too less as of now.
Okay, sir.
Considering that this is a myasthenia case, perhaps.
Okay.
I've had a point.
Yeah.
No, if Akshay hadn't told me that this could be myasthenia and just showed the case to me, I probably would have put myasthenia as my, corner diagnosis. Like Soumya and everybody is noticing, the ptosis is really, really very minimal and constant. And if you see grossly, look at his face, he has a lot of facial asymmetry. Left eye looks prominent, more than right eye looking ptotic. Left eye, I feel, looks prominent, and he fixes with the right eye. It is more of a pseudotosis kind of a thing. But of course, it's really confusing. And on top of it, the test is coming positive. And so, like we say for all strabismus, we don't yet probably are very sure, but I would more consider that it is not myasthenia.
Okay.
Right, so unless he really responds to the treatment, and when we combine with Gravitor and steroid, there should be a little better response. Even though the steroid is a very minimal dose they have given, we expect with a combination, he's given a combination, right? Not just steroids.
Yes, ma'am.
Then there should be a little bit change, at least in the doses, and disproportionate amount of limitation is only -1 compared to the amount of XT. So kind of, you can have long-standing exotropia, you can have a limitation of adduction, So FDT was it kind of tried? So I would say
I didn't.
if he still doesn't respond to the thing, then leave the myasthenia diagnosis kind of in the side and do FDT, and then if everything, we manage him like a constant exotropia and probably offer surgery if angles are stable.
Okay. Sure.
But very interesting, very confusing case. Thank you.
Yeah, nice case, Akshay. I think Dr. Shikha has asked whether there was thinning of muscles on MRI. MRI was normal.
Shikha, I'm not sure. CPO, the prominent feature will be limitation, yeah. And more ptosis. CPO patients will have kind of more ptosis. But yeah, absence of diplopia, large XT, CPO is also in the background, but they will have more limitation of movements.
Was there any thinning of the muscles noted on the MRI? Just to differentiate between, concomitant squint and this thing, myopathy.
So the
chronic myopathy.
grossly looking normal. I mean, I saw for thyroid, wanted to make sure there was no thickening of the muscles, but measurements per se were not taken to say it was thin or thick. So
No, that will really add value if you're thinking that it's just a concomitant squint with large angles or some myopathy, chronic myopathy, or some neurological cause there. Then some amount of thinning, even in untreated myasthenia of long duration, you'll have some thinning of the muscles, wasting. Some muscle wasting is noted.
I'll get a reporting of his MRI with regard to this one. Okay. And repeat the ACH receptor. Okay.
Sure.
Nice, Akshay. Very nice documentation, nice videos, and a very interesting case. I think we all come across these cases which are like we don't really know what to do with them and what to tell them also sometimes. So I think it's we have had a good discussion. So we'll go to your second case now.
Yes, yeah. So this was a 3.5-year-old child with oculocutaneous albinism, presented with abnormal head posture for distance and near. Parents felt that he was unable to see clearly for distance, and he was born of second-degree consanguinity, full term, no birth asphyxia. Development was normal. So there was no history of previous glassware, trauma, surgery, no known systemic illnesses. So in examination, his general appearance was a classic ocular albinism with albinic hair and skin, and he had a prominent right head tilt and a right face turn, and horizontal jerk nystagmus, right beating with also a convergence null. Ocular movements were full, and cover test showed a flick exophoria. And the rest of the examination, iris had transillumination defects. It was hypochromic. There was a diaphanous glow. Lens was clear. Yeah, so this was his abnormal head posture, a right face turn and a right head tilt for distance. And this one was for near. Yeah, and about his sensory test, stereopsis was 4 dark seconds with stereo animals. Vision was 624 monocularly, N10 at 20 centimeters. And they didn't get an AR, so I did a retinoscopy. It was +3 with the 4.75 cylinder at 180 and +2 with -3 cylinder at 160 in the left eye. And I gave him, and of course the fundus was typical albinic fundus. He had a foveal hypoplasia of 1A, 1B. This is just to explain the foveal hypoplasia. And I gave this glass prescription. So this was the previous one. And so with glasses, this was the AHP. So this is 2 weeks of wearing the glass. So his there was a slight face turn, but there was a good change in the head tilt just with the astigmatic glasses. So then I just read about the association of foveal hypoplasia with vision. So from his OCT, he basically has a 1A, 1B type of foveal hypoplasia, wherein the pit alone is very shallow. And for albinism, children who are having a fovea of this structure, usually they'll have a logmar acuity of 0.65, and his vision is 624, which roughly corresponds to logmar acuity of 0.65. But the glasses still change the abnormal head posture, so it is important to correct the refractive errors in albinism, even if there is foveal hypoplasia, at least to correct the abnormal head posture and not think that the AHP is only because of nystagmus.
Thanks, Akshay. I think your case shows the value of any head posture that we see. The first thing is treat whatever is treatable. So there's a refractive error, treat the refractive error. So I think your case beautifully highlights that. I would go to Dr. Rishikesh Mai here. Dr. Rishikesh, again, you have done quite a bit of work on albinism. Could you, from your research that you have done, could you throw some light on what you normally see in children, and if you come across a case with an AHP, how do you approach it?
Actually, we had done a study for 3 years for cases of albinism. Actually, I have one pediatrician, fortunately, in my the same complex, and he keeps referring cases to me. So, one of the important findings which we had noted, it has already been published, is that astigmatism is the most common refractive error in the albinism. So, if even if you correct the astigmatic correction, I think that is what your case also had, Akshay. So that itself is able to correct a significant amount of abnormal head posture, especially head tilts. So probably those head tilts get corrected with the astigmatic correction itself. And few other things which we observed was, it was a case of I think around 20 cases we had observed over 3 years, and we found that apart from astigmatism, the next common refractive error is hyperopia. The problem is with the visual prognosis is good if it is OCA2 compared to OCA1 or 1A or OCA1B. Astigmatism, presence of only astigmatism usually has better visual prognosis compared to the hyperopia, which has really bad prognosis. And we try to compare the different types of refractive error. We considered astigmatism as only those cases who had only astigmatism without any spherical value. So, however, as far as refractive error is concerned, the second most common is hyperopia, which has comparatively poor visual outcome in these cases. So,
this was a case of hyperopia with astigmatism. He had a flick exophoria, so I just gave the cylinder number.
Yeah, you mentioned hyperopia with astigmatism, but I think prescription was only for the astigmatism.
Yes, sir. So after I started reading, I just had a doubt. I just read that the emmetropization process also is affected in albinism. So will it be necessary for us to correct the hyperopia also? How does it relate to the emmetropization? So supposing we usually see hyperopia and astigmatism. So do we take off the plus according to the age? That is what I did. But should we give plus for considering that emmetropization is not going to anyway be affected by giving the plus? How do we understand that, sir?
I think I usually follow the same rule as for all the other children as far as giving a hyperopic correction is concerned. Obviously, you must have done the subjective refraction. With hyperopia and without hyperopia. And did you notice any improvement in binocular visual acuity in the logMAR child?
No, sir. I have given only astigmatic correction, and in 2 weeks I saw vision was still the same. And his stereopsis was still the same, but there was a change in the head tilt.
The head tilt improvement is because of the astigmatism, not because of the hyperopia. But I think I would have done the same. I would have given only the astigmatic correction, which was significantly high. So even I would have prescribed the same.
Okay.
How much was the hyperopia?
So +3 and +3.5, ma'am, something like that.
Okay. But
this is with the
but we don't reduce the whole plus, right?
Yes, ma'am.
I wouldn't have reduced entire +3.
So 1 second.
I would have reduced around 2 and 1.5.
Okay, ma'am. I'll just tell you
because subjectively you could not do, no? It's a 3-year-old child.
Yes, ma'am. He had this thing, +3 in the right eye, +2 in the left eye, ma'am.
Okay.
And he had an exophoria unaided.
Right. So mostly I would have also corrected the astigmatism and I think refractive error correction is as per how you would otherwise correct. Nothing specific for albinism as such, unless the child is not tolerating, once an older child, if not tolerating hypermetropia. Otherwise, I think we should just follow the usual standard thing. Yeah, and you can't overstate the importance of refractive error correction in any patient with any other underlying condition. And like you said, very nice improvement even in AHP.
Yeah.
Ma'am, just one more doubt I had when I came across this thing. So there is a correlation of foveal hypoplasia with vision. That's something I came across and read. So should we all try patching for this child or just leave it, ma'am? Because his foveal hypoplasia level and visual acuity level matches. meaning he will not improve further. We will not expect an improvement further than this. So, but still, can we try patching or?
Patching, what do you mean? Say if it is bilateral patching, you mean alternate patching?
Alternate.
See, generally, it is even for amblyopia, if it is a bilaterally symmetric refractive error, alternate patching has a very kind of mixed role. We don't really, I'm not very pro for alternate patching, and you have some equal vision and orthophoria, no anisometropia, patching may not have a role.
Anisometropia meaning 4.75 and 3.25, ma'am.
See, if vision is unequal and you have a demonstrable anisometropia, you can patch the better eye, like you would for any other child. But alternate patching, if there is equal vision, maybe may not work, may work.
Okay, ma'am. Understood. Yeah.
Yeah, I would like to ask the next question to both doctors Soumya and Dr. KKV ma'am also. Now, in this case, the child did well with glasses. Many times we find these situations where the children come, we have given them glasses, AHP has not improved at all. They still have a large tilt and turn. And how do we now take the next step? Same 3-year-old child who has, say, a hyperopia with astigmatism. What next? He's not improved with glasses, so what do we do? How do we go next?
Prisms. See, I have a very strong positive thing for prisms, even in young children with significant demonstrable AHP, which can be really inconvenient for day-to-day work. I mean, a trial of prisms. We can do a trial, subjectively see in our clinic if there is any significant improvement. Even if we don't demonstrate significant improvement in OPD in the clinic, we can actually give a trial of prisms. They really do well, even if the AHP is the first thing we are looking at for improvement, but even visual acuity, even the amplitude of nystagmus kind of as a secondary thing improves, and visual acuity improves. But we have to push glasses like in any other if refractive error is significant. Next step, high refractive errors, contact lens is a very good option, even for young children. If refractive errors are high, do well. Not just albinism, any other type of nystagmus with contact lens. If glasses they are not compliant to. So, what is your take on prisms, Soumya?
Yeah, I agree with whatever you said. Just that the hyperopia, I would probably tilt towards giving a hyperopic correction, because I presume that the hyperopia is the one which is causing the face turn here, and the astigmatism is the one which is leading to a head tilt. So I would be more towards giving the small hyperopic correction. And two, probably I would differ a bit in terms of alternate patching. Yes, we don't know exact role in terms of patch or otherwise. I mean, most often than not, I tend to give alternate patching in most of the cases that I see. Though I see it as what ma'am was mentioning, it is symmetrical refractive error, not measurable visual difference. Like in cases of where there is an organic abnormality already existing, like a foveal hyperplasia, I would still give a trial of patching before I said this is the version matching with the structural abnormality, because there is no exact understanding in terms of a structural functional relationship in a foveal hyperplasia. I've seen even in the literature also, though we know that this should lead on to this amount of it, there may be much more structural anomalies and the vision could be much better than what we expect in that structural anomaly. In that scenario, I would kind of be biased towards doing an alternate patching and then taking a call. Yes, in terms of if it is a 3-year-old child and we are giving glasses, no improvement in the HP, the next call would be to take prisms, as what ma'am mentioned. Prism would be the take, because it would definitely wait till 7 years of age before you would want to do anything substantial to improve the AHP. Considering these children would develop other corneal issues or other glaucomatous issues which could crop up with time, or the refraction itself changing with time. We would not tend towards doing anything in terms of AHP correction till you're sure that this vision is what it is improving up to.
Can I ask a question?
Yeah, please. Yes, please go ahead.
Actually, I just saw a patient today. Just fast forward your case just presented to 3 years more. The patient which I saw is 6-year-old with oculocutaneous albinism. Her vision is 6/18, binocular as well as uniocular. There is no AHP which has got corrected with the astigmatic correction which I have given, but she has a esotropia now. I mean, she's 6 years old, so I feel now it's a time to correct her esotropia. I wanted to know whether anything different I have to do, because I haven't done surgical correction for a case of oculocutaneous albinism esotropia. So we follow the same norm as a routine esotropia case, or anything different?
I think you could see if you're having same principle, right? Like if you remove the ocular albinism part of the in the equation and just see if vision is equal, constant angles, corrected the refractive error, and definitely you can offer surgical correction to the esotropia if it is constant and significant. I think patients do really well. You don't have to withhold surgery if you're done. Even exotropia, esotropia, if vision is equal, I think same as any
Same
other
principles.
situation. As long as because albinism as such is symmetric, bilateral, constant. So you could
Yeah,
offer
it's constant over like almost a year now. So
you should offer
Yeah. I think Dr. Sandeep Tirumalai also has messaged. He said if there is no face turn, you can follow the routine surgical plan, routine surgery. You can do it like a routine surgery.
correct.
The challenge would be
nice
to
case.
measure the deviation probably in the
It's very
presence
tough
of
to measure.
nystagmus.
That's the
Challenge comes with respect to get the exact measurements before you plan a surgery.
True.
The
Sometimes
problem lies there rather than in your measurement.
more than the PBCT, Krimsky helps. In these situations, you do PBCT, Krimsky kind of reflex tests can be kind of, as an adjunct. And you really wait for making sure the angles are stable, all the precautions.
Dr. Rishikesh, anything you would want to add from the study you did on ocular albinism? Maybe 3 or 4 points which you felt were something that you learned new or which surprised you?
The important conclusions which we found from our study was that as far as the indicators, because you have to explain the prognosis to the parents, that presence of astigmatism and OCA2, and usually they have a better prognosis. OCA1A and a presence of hyperopia usually is associated with a poor visual outcome in these cases. So our study was we did from 6 to 15 years of age, 4 to 16 years of age. And this is what we could draw the conclusion.
And
Right.
I have a question, maybe Soumya. See, some of these children have cataracts now. Some of these children can present with cataracts. So, any tips on how do you manage the cataracts with albinism? Any IOLs you will modify? Any type of special IOLs?
Not operated any, so it would only be theoretical if I spoke something. But yeah, yes, it would be a good idea to.
Rishi, you have had any patients? See, I have had.
I manage them like just like
to operate complete ocular cutaneous albinism children. I haven't had anybody presenting with cataract as such, but I have had 2-3 patients with the partial albinisms, but they do really, really well with our regular type of management where you do BPC, anti-vitrectomy, and you can put lens in the back. They don't have glare. And another important thing we are all not talking about is photophobia. But the disproportionate number of patients actually have photophobia comparatively less as we expect, even though they might have completely anaeritic, not anaeric. Photophobia also can be a feature, not very rare. But yes, cataract surgery, I have done 1 or 2, not seen with total albinism, but
Partial albinism I have seen. I have managed also, but I have put the routine hydrophobic lens.
Routine IOL, and they kind of do well.
Yeah, they usually have good results.
Nothing else changes, but yeah, they do well. And Dr. Mona is there. What is glaucoma? Is it a
Yes, some of them have angle dysgenesis. It's not that common, but we do see, especially there are some syndromes which are coupled with aniridia, which have this kind of a fundus, as well as albinism also. So that we usually manage like any glaucoma patient. More than like first line is usually medical, and then usually they may need surgery, mostly trabeculectomy or glaucoma drainage devices. A word about the IOLs. I was going through the publications, so I just saw that there were some publications with iris implants in these children, in the adults, not children, with the albinism, where they have iris atrophy. And so our experience seen in glaucoma, we've seen some patient with those iris implants. They cause a lot of UGH, even though they are the recent ones. So
exactly,
I would recommend those.
Since you are the one who are seeing these patients, it's not a good thing, right?
Yeah.
Because glaucoma is what they. So we don't have any experience in SN as such.
Yeah, not in these, but in the patients who, for change of the color of the, instead of using a contact lens, go in for these implants, usually in the media, we also have a publication on that, So that led to very bad glaucoma.
No personal experience, and never had very good reports of people who have had experience with patients who wanted these kind of iris prosthesis. So I don't have any say or any opinion on it, except that it is really glaucomogenic. It's like you are fishing for trouble.
Glaucoma and uveogenic, I would say.
Yeah. So I really appreciate Akshaya's really variety of nice, interesting cases.
Yeah, interesting cases. Both the cases. A lot to learn. Thank you.
Thank you, sir. Thank you.
So I think we are 4 minutes away. Any concluding comments, or anyone has anything to add?
It's probably that foveal hyperplasia can be an isolated entity as well, not necessarily associated with albinism. So if you have any case with an nystagmus and not able to explain, probably look at the fundus a little more in detail. Because it's get missed in a child when you're doing just an IDO and not looking at 90-day or a 78-day examination. So an isolated foveal hyperplasia is something that has to be running on your mind when you're looking at a case with nystagmus as well, without albinism or an aniridia, which can be a straight cut indicator towards the same.
Very, very true. Just the fundus will look normal, and you kind of. So the pendular nystagmus would be the clue in those situations. The nystagmus will be pendular. So when you see a pendular nystagmus, you look for the foveal reflex.
For a 3.5-year-old child, you got a good OCT because I have had tough time doing OCT for these children, especially with nystagmus.
Quite cooperative, sir.
Yeah, so I think we had 2 very good cases. The first case was a large exotropia with a pattern, with a hypertropia also, and Akshaya demonstrated some lid fissure and lid changes also, which was ACH receptor antibody positive. And then we were debating whether it is myasthenia or myasthenia is unrelated, and very interesting case. And the second case was a case of ocular albinism with a refractive error, with a abnormal head posture, which you gave glasses and you showed us the benefit and reiterated the benefit of doing the simple things in these difficult cases. You treat the refractive error and many times they actually get better. So thank you, Akshaya. Thank you for those cases.
Thank you, sir. Thank you so much. Thank you for giving me the opportunity, sir.
Yes, I would now like to invite Dr. Mona Surana for the concluding remarks.
Okay, thank you so much. It's usually my summary from the non-specialist side. So I first of all congratulate Dr. Akshaya for putting together such interesting cases and beautiful videos. And she had everyone put on their thinking hats and scratching their heads to reach to a diagnosis for the first case, which was myasthenia masquerader, which again was still mystifying for everyone till the end. So it started from a simple divergent squint after a COVID vaccine and with simple astenopic symptoms, but then had everyone discussing all the differential diagnosis. And what I picked up from the discussion was that for myasthenia, it's good to do all the clinical tests like the curtain test, the Kogan lid twitch sign, the eyes test, and do all the battery of tests. And in case any test is not fitting in, like Dr. Soumya said, good to repeat the test in a different lab. I also came across a DAPL sign where you have to repeat the test 5 times. And strabismus may not respond as well as cases to the treatment with steroids, and it's good to give an adequate dose, which is 35 to 40% of the body weight. And then variability is the key in ocular myasthenia, and good to document it before clinching the diagnosis. And going on to the second case, which was very simple to start with, but it tells us the power of simple things and how simple solutions to complex problems can make everyone happy, and the power of power glasses. Good to correct the astigmatism. Hyperopia, there was a debate whether to correct it fully or to not. And patching also is important. And again, if it's similar refractive error in both eyes and similar vision, then it's your choice whether to go ahead with alternate patching or not. If glasses don't work in correcting the abnormal head posture, go to prisms or even contact lenses in high refractive errors. And when the child is older, surgical correction as per the usual guidelines. And measurements in nystagmus are difficult, and Dr. KKV suggested the Krimsky test. So I really learned a lot from this discussion, and great presentation and great discussion by everyone, and great comments.
Now I'm afraid you won't send across to squint department, yeah?
Or I may send more.
Anyway, very nice.
So next month is, I think, back to glaucoma from SNK. POWWOW. So please do join.
All the best. Yeah.
Recording will be available in a few days.
So thank you, Akshay, for nicely moderating.
Yeah.
Thank you, ma'am. Thanks to Dr. Soumya,
Thank you for the
Dr.
interesting
Rishikesh, and
cases.
to KKB ma'am also for very nice. We had a very nice discussion. Thanks to all of you. Thanks to the Ecom team for putting
Thanks,
together everything.
Dr. Shika.
Yes, thank you, Dr. Shika, your brainchild, and Akshaya for coming and presenting despite your fracture and all that. So thanks a lot.
Thanks to all
Thank
the
you, ma'am.
academics supporting the idea and everybody joining. I see that Dr. Vijay Tomar is always there. Every time he's supporting, be it whichever specialty, he's always logging in. Likewise, I saw this time a lot of other specialty alumni is also logged in. Great, Prabhat was also there. Yeah, it's nice to be back, every month connecting with everyone. Thank you.
Thank you, everyone. Thank you.
Thank you so
Good
much,
night.
ma'am.
Good night.
Bye, guys.
Good night.
Good night.
Bye. Good night.